in Nepal, throughout the world, is kind of very unpredictable. We are facing a lot of problem, but even then, we should continue with our academic activities. I'm very happy, being the president of ASON. We have so much, all of you being actively present. I feel very fortunate to have all of you as active members of ASON and continue our academic. We have to continue with that. So I think Silas will not be joining us. So Vivek is here. We have three prominent speakers here today, all expert in their field. So first of all, I want to thank them for participating, giving the time to speak, to come to our request. So for further taking more time, Vivek, are you going to coordinate?
Sir.
Okay, Vijendra, you can please invite our speakers, STEAM speakers, and then we start our program.
Thank you, sir. Respected professors, seniors, and dear friends, on the behalf of Arthroscopy Society of Nepal, I'd like to welcome to you all in this ASON webinar. So previously we have discussed about the graft harvest techniques. We have detailedly talked about the quadriceps graft, BTV graft, peroneus longus, and one whole series was about the hamstring grafts. So today basically we will be talking about the tunnel preparation and the graft fixation options. So we have got the three expert speaker today, and I like to thank all the expert speaker for taking out their time and presenting in this platform. And thank you, Rajiv sir, thank you, Naveen sir, and thank you, Arjun sir. So first of all, without any delay, with the permission of our President Iswar sir, I'd like to welcome first speaker, Dr. Rajiv sir, and he will be presenting on how I make my femoral tunnel. So Rajiv sir, are you ready, sir?
Yeah, yes, Vijendra, I'm ready.
So, sir, can you share the screen, sir?
Okay, am I visible?
Yes, sir, you are visible and audible too, sir.
Okay, thank you. Okay, so I'm going to start. So good morning, everybody.
Sir, full screen.
Yeah, one sec. I'm going to do that, Vijendra, one sec.
Okay, sir.
So good morning, everybody. To all the executive members of ASON and all the other participants, happy birthday, Ishwardai, again. So today I'm going to be speaking on how I make my femoral tunnel. I'm going to be speaking regarding the different options, and I'm going to be talking about the technique that I use to make an anatomic femoral tunnel. I want to start by saying that restoration of anatomy is the key to success in any procedure, in any surgical procedure. So the making of the femoral tunnel has always has been the focus of numerous cadaveric and clinical studies. So that highlights the importance. And if there is an improper placement of any of the bony tunnels, then that is a major reason for ACL failure. Now, before I begin my talk, I would ask you all to write down on a paper, or just to remember in your mind, what is your choice of femoral tunnel? So what is the choice of your femoral tunnel position that you've been using? Okay, and after this talk, maybe we can revise and see how it has helped you. Now, the femoral attachment site of the ACL is described as an oval-shaped and is divided into two distinct bands. And these bands are named according to the tibial attachment sites. So you have the anteromedial band and the posterolateral bundle. Now, anatomy is very crucial when you're planning to make your femoral tunnel. The anteromedial bundle, it attaches proximally, as you can see in the picture here. It attaches proximally and posteriorly to the posterolateral bundle on the femur. And together, these bundles create an attachment oriented with the long axis of the femur. Okay, that is an extension. Now, there is a variation of anatomy with knee flexion, and the center of the insertion of the ACL is located proximal and posterior, as you can see in the picture, to the bony lateral intercondylar ridge. And this was coined as the residence ridge by Clancy in the late 1990s. The optimal knee flexion angle to determine femoral tunnel placement has been reported to be 90 degrees because the ACL footprint can be more accurately reproduced with the knee in this position. So this is how we actually visualize it. However, when we perform our femoral drilling, the knee is taken into a flexion of about 120 degrees. And we must understand this because this is the position of the knee when we are making our, when we are putting in a bead pin. So this is a lower and a shallower position seen via when we do a arthroscopy. Now, there are different techniques that one can use to make a femoral tunnel. My choice of technique is the transportal technique because it gives me a high freedom of selecting an anatomical femoral tunnel position. Portals are a must for ACL surgery. They're very, very important part of the procedure. And we establish a high anterolateral portal at the inferior pole of the patella, close to the lateral border of the patellar tendon, as you can see in the picture. A high anterolateral portal places the arthroscope above the widest part of the fat pad, and it minimizes interference of the visual field because of the fat pad. Okay? And it sort of gives you a bird's eye view into the joint. The anteromedial portal also, I prefer a high anteromedial portal, and the accessory anteromedial portal is very critical. And if you misplace or if you put your anteromedial portal in the wrong place, then it will compromise the length of the tunnel. So you must be very careful in making your accessory anteromedial portal. And usually textbooks describe it as 2.5 centimeters medial to the anteromedial tunnel and just above the meniscus. Placing the accessory anteromedial portal too close to the anteromedial portal will lead to instrument crowding. So when we are doing our ACL, we are visualizing through the anteromedial portal. So, and then you are putting your drill through the accessory anteromedial portal. So if you put them too close together, then you will have a lot of overcrowding and it's going to be difficult to make your tunnel. The viewing portal during femoral tunnel placement is the anteromedial portal, and the other portals are used as the working portals. Now, there are various options that you can use to make a proper femoral tunnel, and these are usually done using landmarks or measurement tools. For example, the native ACL footprint is also a good denominator to tell you where to place your tunnel. Identification of the lateral intercondylar and the bifurcate ridges. There is an arthroscopic ruler method that is used also, and an intraoperative fluoroscopy and grid system, of which I don't have any experience. Now, identification of the native ACL footprint can be done, and from here, you can get a good view of the intercondylar notch through the anteromedial portal. You can get a good view of the intercondylar notch and the ACL attachment. You can even see that via the anteromedial portal or the accessory anteromedial portal. So you can see the footprint right there. So that will be a good guide. If these cases are recent ACL tears, then this would be a good guide. If you're dealing with the long-term, long chronic ACL tears, then the footprint may not be available to help you in certain cases. Otherwise, this is a very, very good guide. Now, viewing the ACL femoral attachment site through the anteromedial portal provides a good orthogonal view of the lateral wall of the notch. So this allows accurate assessment of the femoral tunnel position, and we like to classify them because the knee keeps changing. Like I showed you, the angle keeps changing. So we like to classify it as high, which usually means anterior, low, which means posterior, shallow, which means distal portion of the femur, and proximal to avoid confusion. So this is how we classify it. And then we mark the borders of the footprint. And then we insert an owl through the accessory anteromedial portal and mark the center. So this is the identification done. Now, talking about the identification using the lateral intercondylar and the bifurcate ridges. So identify the lateral intercondylar ridge as seen in your picture there. Learn to identify the bifurcate ridge, and the lateral intercondylar ridge is identified by starting dissection in the lower part of the footprint. So you can take your RF to the lower part when you're beginning and work from down to up, so that intercondylar ridge you will feel the ridge when you're coming from down to up. So you work from an inferior direction and come to a superior direction. A distinct endpoint is usually encountered as the RF contacts the ridge. Okay. So the center of the ACL femoral attachment in the high-low direction is located halfway between these two landmarks. So we position the tip of the owl through the accessory anteromedial portal and mark the center of the ACL attachment at a point just deep to the bifurcate ridge and at the mid-high-low position, like I told you before, as you can see in the picture. Okay. Now, this is a method using the ruler. We used to do this before. So the ruler was passed, you are viewing through the anteromedial portal. I'm again repeating this. You are viewing through the anteromedial portal. Your owl is coming in through the accessory anteromedial portal, and the ruler comes in from the anterolateral portal. Okay, so this is how it's done. So the high-low position of the ACL femoral tunnel is located halfway in between the lateral intercondylar ridge that I showed you in the previous picture and the articular margin. So you place your ruler just halfway. And the center of the ACL femoral attachment lies slightly deep, proximal to the bifurcate articular cartilage border. Okay. So another method is using intraoperative fluoroscopy and grid. This is known as the Bernard-Hertel grid. I have no experience with this method. Now, they say at present is the most accurate method. And with the knee at 90 degrees flexion, the owl is positioned at the chosen point. You need a C-arm to do this, and you need to get a true lateral view with both the condyles overlapped. And the grid system was described by Bernard and Hertel, like I told you, and it is used to measure the position of the ACL femoral tunnel. Now I'm going to show you a short video on how I make my femoral tunnel, how I make it anatomic. So this is how it goes. So the accessory anteromedial portal is being made just above the meniscus, and we make sure that the medial femoral condyle is safe. A medial portal which is placed too close to the medial femoral condyle can result in injury to the cartilage. And the needle is aimed, as you could see, at the femoral ACL footprint. Now, the fat around the PCL, which is obstructing our view, okay, is being cleared. And this is important as the accessory anteromedial portal from where we are viewing is the working portal in this technique. And the passage must be clear for the instrumentation. So we're going to place our guide wire, our cannulated drill bit, then the drill bit for the femur. So it must be clear. Now I am clearing the footprint. So I'm still clearing the fat pad out here, okay, to give you a good view. I'm doing it very slowly because this is a basic ASON webinar. So the beginners here also will understand. So I'm using the radio frequency to clear. We usually don't clear to so much of an extent because this one we're going to clear quite a lot to show you everything in detail. So see, the condyle needs to be visualized, okay? Now the footprint is being cleared to show you the ridges. Usually so much footprint does not need to be cleared like I told you, right? The posterior portion of the condyle is being cleared to view the deep end of the condyle, okay? So the condyle has to be visualized because we need to assess the length using a ruler or whatever you want to use, or you want to use a femoral offset, which I'll show you in a little while. The distance between the deep and shallow ends need to be measured sometimes in the absence of the footprint and the ridges. So that's how we clean from inferior to superior. Now to view the ridges, the RF must be used from downwards in the upward direction. So this abuts the ridges and it acts as a stop and makes them visible. A distinct endpoint will be encountered as the RF contacts the ridge. When present, the lateral intercondylar ridge is critical to anatomical ACL femoral tunnel placement, since the ACL femoral tunnel attachment site always lies below this ridge. So as we go, so that is deep, this is shallow, like I told you. So I'm showing you that with a probe. That is high, that is the intercondylar ridge, lateral intercondylar ridge, and that is the articular surface, right? So somewhere in between that and just behind the bifurcate ridge, that is the point, okay, where we're going to make a tunnel. So I'm showing you there with a probe, okay. Now we're going to insert our owl, okay. This owl is coming in through the accessory anteromedial portal, okay. Again, we confirm our position, lateral intercondylar ridge, articular surface, midpoint, just behind the bifurcate ridge. Okay, and after confirmation, so we've placed a point there, and after confirmation, you use a hammer to make a small hole there with your owl. I'm combining two methods here. So this is, I'm relying on anatomy, and I will use, so this is by anatomy, I've made my point there. So I'm going to use what I use these days. It's a medial portal aimer. Okay, so I'm going to come in. So that is the hole. And I'm going to come in with a medial portal aimer and I'm trying to confirm whether my anatomy is good. So I'm going to place my medial portal aimer. The longer part is gone towards the back. It's hitched at the back, and see, that's where the guide pin goes. So that is the correct place for the femoral tunnel. Okay, so the knee has been flexed to 120 degrees. Okay, and then we drill a femoral tunnel. So I'm showing you from it. So there's a very thin portion of the bone left posteriorly. There would just be about 1.5 to 2 mm of bone left posteriorly. So this is how we go, and that is the placement of the femoral tunnel, which is anatomic. Now to move on to the next. Now, what is your choice of femoral tunnel after looking at that? So if this is what you've chosen, that was the correct choice of the femoral tunnel. Now, what does literature say regarding the ACL tunnel position? It says that malposition has been reported to be between 10 to 40%, and it is one of the main reasons for revision. And it is in 52% cases that you may see it. And this is attributed to the position of the portals. That's why I highlighted the importance of the portals and the degree of knee flexion during identification. So if you do not have a proper degree of knee flexion, and if you do not identify your ridges and place your portal properly, that also can lead to a wrong or malposition of the tunnel. Anatomical variation is a problem that we deal with, and arthroscopic image distortion is also one of the reasons. So I would like to conclude by saying that it is an important part of ACL reconstruction. So like I told you, we must understand the anatomy well. We must be oriented regarding the position of the knee, and we must establish portals correctly. And it is very important to avoid overcrowding. And this is definitely a very precise technique which requires skill and training. Thank you.
Thank you, Rajesh sir, for your excellent presentation, sir. Rajesh sir, can you stop sharing screen, sir?
Okay, Vijay.
Yes, sir. Thank you, sir. So, is there any question and queries regarding the femoral tunnel preparation?
Yes, hello.
Yes, I can hear somebody who's
Sanjeev.
Yes, sir, nice presentation, sir. I would like to ask one
Thank you,
question. If
Sandeep.
there
Yeah.
is, if there is a femoral blowout while doing surgery, and what will be my next position?
Okay, Sanjeev. The thing is, Sanjeev, see, how to avoid a femoral blowout, first we'll say, right? So your tunnel must be in the correct position. We must not be scared to go posterior, see, because if we are scared to create a femoral blowout and we don't go posterior, then we'll land up with an anterior tunnel, which will be a big mess also. There are problems with that also, okay? But in the case, what is important to avoid a femoral blowout is proper portal placement and your knee flexion. Okay, I think your knee flexion is very, very important. Now, in the case where you have a femoral blowout, there are a lot of bailouts. Okay, the most reliable bailout, I think, is to go from outside. Okay, I think for beginners, for the most reliable blowout is to go from outside, make an incision, and put a screw. Okay, with a washer, you put the screw antero-distally. Okay, and try and avoid the iliotibial band. Okay, if you put in the wrong position, the iliotibial band will keep rubbing on that screw and the patient will have problems. And you take out your thread from the graft and you tie it on that screw. That's the most reliable one. The other one is if your outer cortex is intact, if you haven't gone through and through with your big drill bit, you can use something which is known as an extendo button. Okay, so if you're using an endo button, the extendo button is a bigger button which fits onto the endo button. If you look up the Smith and Nephew site, this is the name that is given by Smith and Nephew. Yeah, it is a bigger button, so that can go again. You flip that, and then that can go stay in the cortex. Now the different hybrids also mentioned. For example, if you have a good amount of cortical rim left at the back, then you can do a fixation with an endo button and an interference screw also. But I think the most reliable thing for a blowout would be to put in a screw from the outside with a washer and tie your threads of the graft from there. I think that would be the most common. You must know regarding femoral blowout, you must always have a plan because at times it can blow out and you will really panic if you don't have a plan. We don't have extendo buttons in the OT. Okay, at least when I do an ACL, I always don't have an extendo button at hand. So I mean, the screw and the washer you would have in most of our orthopedic OTs, right? So that is a good bailout if you have a posterior blowout. Did I answer your question, Sanjeev?
Yes, sir. Thank you, sir.
Uh,
Dr. Rajiv,
Yes, yes.
do you confirm by CM in common cases or occasionally?
I don't always confirm by Siam. I always don't confirm by Siam because you're saying the endo button. You're talking about the endo button, you know?
Yes, during
Yeah.
portal preparation.
No, I don't confirm by Siam. No, I don't confirm by Siam. Like I said, that is a method that is used. I have no experience in using that method. I don't confirm by Siam.
Okay, thank you.
uh, can I just make a comment? Yeah.
Definitely, definitely.
Rajiv, excellent presentation. I
Thanks,
thank
guys.
you for that. It was a real anteromedial observation and accessory anteromedial working. Um, just taking on what Sanjeev was asking, he's quite right to ask that. It's been taught very widely that posterior blowout, that can occur anywhere. For everybody, it's a fear. But I frankly would like to ask Rajiv, have you had a blowout in your practice?
Luckily, till today, in my practice in Nepal, I haven't had a blown out, right? But I have
Okay,
seen
good.
blowouts. During my fellowship,
Good.
I have seen a blowout,
You have
and
seen a blowout.
I have seen a blowout. Right, I've seen a blowout.
Okay.
See, the thing is, during fellowship, we're all learning, right? So there were a lot of fellows. Like for example, Dhakaman, right? In Nitor, I saw
Uh,
DHS cutouts.
no,
I
that
saw
was that. Dhaka, you
it's like a
don't.
factory. Oh, it's like a factory then. So like
So,
KMCMA, we've never had a blowout of
so
of
that
the
is what I'm.
DHS. That is because Azuku, they're experienced surgeons doing it. Right? Our residents are they got that, trainees are they got that. So posterior
All.
blowout, I saw one case being managed by this extendo button. It was
Okay.
managed quite well. And another case, I saw an older surgeon do that screw and washer fixation. That is the most secure thing. And in an orthopedic OT, that is always present. You may not have an extendo button,
Yeah,
but a
the
screw and
post and the.
washer you'll have. So that is a good bailout. So you shouldn't think past it, and screw and button, I think.
So to tell you my experience, our experience at BNB, like
Awesome.
everybody becomes experienced only after some years. We start from what we know, but touch wood, I don't know, like we have, I don't boast that we have done so much of ACL, but I also asked my colleague Amit, like blowout has been, it's kind of overrated a problem, I would say. We have definitely done hundreds, but maybe we are a very cautious surgeon or anything like that. We have not had a blowout. So there are many things written about how to tackle a blowout. One of those, Rajiv has very clearly pointed. It depends upon where the blowout is, how far whether it's a posterior cortex or in the medial aperture only, or whether it's extending onto the lateral cortex. There are many ways, but I tell you practically, I have not had any blowout so far. Maybe because we have a lot of precautions, we do it in a different way. I wanted to, and every surgeon has their own way of doing femoral tunnel, all their tunnel preparation. And I just wanted to ask there is this people nowadays, you showed it very nicely, you put your scope in the anteromedial portal, you see everything doing from your accessory anteromedial portal by your keeping your, actually, it's the anterolateral portal that is the viewing portal, and anteromedial you do your working portal. That is the standard teaching for the upcoming arthroscopic surgeon. But when you do anatomical transportal technique, your anteromedial becomes your viewing portal and accessory anteromedial. And it's very nicely you showed everything step by step, and everybody has their own way of doing. If I tell you my experience, I just look through the anteromedial portal. I feel that, like you did point out that when you don't make your anteromedial and accessory anteromedial portal accurately, you have the crowding of the scope, and the and your instrument, so there is a very little space there even, so that would be very, difficult for the younger surgeons to understand. They should, really look up to where you put your anteromedial portal and accessory anteromedial portal. And there are people now, even experienced surgeons, who say that it's better to make a horizontal anteromedial portal, just one single portal, and then, you can stretch it to the accessory point and make a, and I don't know how they do that. That's pretty tough, I would say. But what you showed was very nice. I just wanted to say that two portals in one side of the patellar tendon is very, very difficult. That is the trick you have to learn, learn by seeing how it is being done. It's very well written in books. You make your accessory anteromedial portal, and then when you start doing it, you have your scope as well as the instrument on the same side of patellar tendon, and then, it becomes a tricky thing. The other thing I wanted to talk about was putting your jig, it's very nice, you showed that you mark your point, the center point with your all that we are also trying, Amit is doing it. I stopped doing ACL quite a long time, after our fellows and peoples are coming, younger associates are coming there, but that's a very good technique. You're marking your point where you want to even to put your femoral offset jig, and that is there. One point I just wanted to point out was that this thing, of course, you said the femoral tunnel placement is a changing thing, and just last night, if most of you people must also joined the IAS meeting, which was given by Andy Williams yesterday, last night. Did you guys join there?
No, I didn't.
So this guy, he's a high volume athletic orthopedic, he treats a lot of elite athletes from England, and he's talking about the central and then going more posterior, the anteromedial band. So for his group of patients, the high professional athletes, he would call it, he makes a anteromedial portal, the tunnel is more in the anteromedial bundle. As Rajiv says, for a normal patient, we would go in the center, which is between the anteromedial on the back and the posterolateral. We try to identify the center point. But for high athlete, there is a difference in where you make your femoral tunnel, because the activities of this athletic demand is quite different from that of the normal FIFO. So this is a changing concept. And at the end, what he said was he was thinking of making his anteromedial portal through the transtibial technique. So there are still people, even in India, who are doing still transtibial femoral tunnel preparation. So it's a changing thing, but we have to follow what Rajiv says, anatomy is the best we want to create, but it's a changing concept, I would say, maybe in the next 5 years, there are this Canadian people, isn't it, who talk about the ideal concept. So that's a different matter. But for the upcoming younger guys who are here with us, anatomic ACL reconstruction, taking the central point of the anteromedial as well as the posterolateral bundle. Either you use a awl or even a femoral offset jig, you can see that. But you should know where you are going. And like I said, after quite a long time of practicing ACL reconstruction, don't have a blowout. That is what you should aim to avoid. So are there any more questions?
Yeah,
So there
I'll
is one
counteract to us. Yeah. Okay, go on, Vijendra Banu.
Rajesh sir,
Yeah.
Dr. Sunil have asked about that. Is there
Yeah.
any anatomical variation that causes difficulty in identifying lateral intercondylar ridge and biperfect ridge?
Yeah. So basically, what I tried, I see the basic thing is what I want to say is basically this presentation is targeted at basic beginners. Okay, mostly. Okay, that is what we are here for today. So I didn't want to confuse them with ideal. We all know ideal. I mean, most of our senior faculty, they know ideal. Most of the people are doing no ideal. So the juniors, you don't want to confuse them with ideal. Because see, at the end of the presentation, they should know where the femoral tunnel lies. Okay. I give them isometric and direct and anatomic and low tension and all that. And at the end of it, they land up with the presentation where they don't know where I put the femoral tunnel. Okay, so that is why my presentation has been simple and it has been very graphic. I have showed you exactly where to put the femoral tunnel.
Yeah, exactly. I totally
Awesome,
agree,
awesome.
Rajiv. Yes,
Number
that's
one.
very
Awesome.
nice.
Now, awesome. To understand, to answer Dr. Sunil Pant's question, now definitely there is anatomical variation. So see, when we are orthopedic surgeons and we do a radius ulna, okay, when we're doing a radius ulna, that is one of the most primary sort of surgeries that we do, right? Radius ulna. So we find out when we do a Henry's approach, just to give you an example that you can relate to, sometimes we find out the structures are not exactly where they should be. There's some anomaly. Okay, there's some anomaly. Everybody agrees to that. There is some anomaly at times when we do our Henry's approach, right? So similarly, also when we look at, as you go on to see your femoral condyles, all of them may not look exactly the same. Okay, like he's saying, the lateral intercondylar ridge may be absent in certain number of cases. It may not be present. It's written in literature. So that is why I have shown you many methods. Okay, I've shown you at least 4 techniques that you should be well versed with. So it will be a bailout. Now, if you have an anatomical footprint, well and good, that will help you. Otherwise, we have these bifurcate ridge and the lateral intercondylar ridge. If that is not there, you can still use the ruler. Otherwise, like, we are using the medial portal aimers now. That is also there. So you must be well versed with the technique. At the end of the procedure, however you do them is not important. Your tunnel must be anatomic. Okay, so that's the message I want to pass.
Thank you,
Because
Rajesh
that is a
sir.
very, very important part of your ACL reconstruction. ACL, I think, is a very, for most people who are doing it, it is easy surgery, but it has to be very precise. If you're not precise and you make small mistakes, you will land up with a blunder.
Yeah,
That's about it.
it must be well planned, well calculated, and it's the first surgery. When you do a first ACL, you should be perfect. When you think that
I can see Naveen smiling also. I'm definitely, Naveen is also smiling. It's easy surgery, guys. It's not difficult, but it has to be very precise. When the first time is the best shot.
Yes, definitely. The first chance is your best shot.
Best shot.
Okay, I think that was a good. Anybody, Dr. Arjun, Dr. Naveen, do you have anything to say? Would you like to comment?
Oh, yeah, the same thing, the way Rajiv has explained very nicely. My way is also doing the same way. Sometimes only I found difficulty in when the patient is very obese, then the hyperflexing the knee becomes very difficult. So in those cases, at present, though answer I know is the basically flexible reamer available at many places. People use flexible reamer with that, no problem. But at my place, that flexible reamer is not there. So in that cases, I found very difficult. Sometimes
Online class also.
Outside in maybe a good technique.
flexing in a big obese thigh is very difficult. You can't get a full flexion. Yeah, I agree. For me, we, like you said, we don't also have a flexible reamer. We use that solid reamer also. And once I put the bead pin with my guide, femoral offset jig, I just do it with, I look from the anterolateral and use the non-flexible, rigid reamer. So the other thing is, if it is too big, if the reamer is 10 size, then you might have problem. But usually with the 8, 9, you can easily pass it through the middle condyle, middle condyle of the femur, with a hand, just using a hand to just roll it into the middle surface of the lateral femoral condyle and then drill after that. Yeah.
Outside in may be a good technique, Dr. Naveen. I've never had such an obese patient, but recommended outside in jig may help you in these patients.
Rajesh sir, I just
Yeah,
have a question.
yeah, Amit. Yeah.
Yeah, in your experience, what is the longest or shortest femoral tunnel length you have experienced, sir?
I think the shortest I've experienced is 28. I think 28, and the longest is I think maybe about 40. These are very abnormal. I usually get a femoral tunnel length of approximately about 34, 36 like that.
I don't know why it has happened, because I used a similar method what you use, Rajiv sir. The longest I experienced in a 48 mm, and the short
48.
yes sir, 48 the longest, and the
My
short
God, that's pretty big. Yeah.
27 in a short young lady. I don't know, is that acceptable, sir? 48 mm?
I think 48 is pretty big. 48 is pretty big, but 27 maybe in small patients. See, the thing is basically, next time when you think, what you could think is basically your tunnel, right? When you see that hole that you make, that should be an oval hole. You should not try and make a round hole. When you're aiming from the accessory anteromedial portal, that hole should be oval. So that oval will give you more of length also, okay, when you're going into your femur. And second of all, it will give more graft, it will give your graft more length also inside that tunnel, because it's an oblique hole, right? Then more round hole. And yes, definitely 27 is quite small, but maybe if it's a small lady, yes, graft size femur also may have been small, but 48 is pretty long. It's quite long. Does anyone else have a comment on this?
My idea is 48. I've never experienced. At the most, I think the longest femoral tunnel I've had is 42 something, 40, 42. The average is something like 36, 34, as you see, but I've never had anything. I mean, if you have something like below than 30, it's very difficult to put a enter button, like, because the amount of femoral amount of graft you want to have inside the femoral tunnel, if you have just 28, is like 1.5, so it's something like 1.13 endo button loop 10. So it's difficult to calculate. You have to leave 5 to 10 for the flipping. So I think the smallest we have had is 30, 32. The longest is 40, 42. Usually it's 36, 38, the average femoral tunnel. Am I right?
I think in my opinion regarding the Amin's question, then the length of the tunnel depends on the portal, the middle portal where you have made. If you have made an inferior medial portal, you can get a longer tunnel, and the oblique type of tunnel is Rajiv mentioned. If you put a quite medial portal, then you can get a shorter one, and that also depends on the size of the patient also. The size of the lateral femoral condyle, that also determines the length of the tunnel. And in other thing, I agree with Dr. Ishwar, Rajiv, and others. Okay.
And Rajiv sir, what is the size of femoral offset jig you usually prefer, sir? 6 or 7?
Yeah, the thing is, see, I mean, it depends on the size of your graft.
Sure.
Okay, you should have all the femoral offsets available. It depends on the size of your graft. You have different ways to calculate, right? You have different ways to calculate, but basically posteriorly. For example, I'll just give you an example. If I have a size 10 graft, then I will use a 7 millimeter offset. Okay, I will use a 7 millimeter offset, because see, half of 10 is 5. Okay, and then I have, see, so the 7, it's going to be 7 millimeters from the back. Okay, from the back of the femoral cortex is going to be 7 millimeters anteriorly. So if 5 of that is taken up by my graft, then there's 2 millimeters at the back. So you should have about 1.5 to 2 millimeters from the posterior cortex. So that's how you calculate. So you should have 5, 6, 7.
Thank you, sir.
Okay,
Right.
I think we should carry on forward with the next topic because it's been nearly an hour. So can we invite Vijendra, invite this next speaker, please?
Thank you very much. So I could like to invite our next expert speaker, Dr. Naveen. So sir will be presenting on about how I make my tibial turner. So Naveen sir, are you ready with your presentation?
Yeah, I'll just share. Thank you, Vijendra. I'll share my desktop. Is it visible, Vijendra?
Yes, sir, it is visible, but presentation is not still open, sir.
It's not open?
No, so just you double click it, sir. It's showing your folder, sir. The folder having a video and your presentation.
Okay.
Just double click the PPT file, sir.
I have opened it. Now you can see.
No, no. So once you stop staring and again reshare. So,
I have stopped share.
okay, and now again reshare it, sir.
First, I open my PowerPoint. No, is that with the way?
हुन्छ हुन्छ त्यो गरे हुन्छ हजुरले पावर पोइन्ट ओपन गर्नु अनि त्यसपछि शेयर गरेर अनि त्यसलाई फुल स्क्रिन गरिदिनु न
मैले PowerPoint ओपन गरे आफ्नो डेस्कटपमा नाउ अब त्यसलाई फुल स्क्रिन गरेर शेयर गर्नु अहिले कि
पछि फुल स्क्रिन गर्दा हुन्छ अहिले शेयर स्क्रिन गर्नु न
शेयर स्क्रिन देखिरहेछ अहिले यो
छैन आयो हजुर हजुर अब हजुरले फुल स्क्रिन गरेर अनि हजुरले स्टार्ट गर्दा हुन्छ
ओके
ओके फाइन सर
okay good morning everybody. First of all, I would like to thank the Arthroscopic Society of Nepal for giving me this opportunity to participate in this webinar. I am Dr. Naveen Kumar Karna from Viratnagar. I'll be talking basically on how I make my tibial tunnel. And on the right side of the picture is the total presentation summary. You can say this is the way I want to make my tibial tunnel. Most of the time I do, sometimes I cannot, but I always try to make my tunnel like this. Now, when we talk of this tunnel placement, there are radiological studies. What they have said, around 10 to 40% tunnel placement in primary ACL reconstruction are reportedly malpositions. So this is very large number of cases. When whatever the type of graft you have used, very expensive or the very latest technology graft fixation you have done, you have had a very best rehabilitation physiotherapist with you. But if your tunnel placement is not good, then your surgery is going to fail. So tunnel malposition lead to the ACL revision surgery. So Dr. Rajiv has already talked very nicely about how you make a femoral tunnel. Now I'll be talking about the best tibial tunnel position that can be achieved by basically three methods. One is arthroscopic landmarks, another is the fluoroscopy assisted method, and third will be the aiming devices. Now, if you are already having a native anterior cruciate ligament remnant over there, then it's become very easy. You just go to the center of it, make your tunnel. But many of the time it is not possible to have you like this. So there are certain studies, Hammer et al., he found that the tibial ACL insertion is around 120% area of the femoral insertion and vary in shape as well. So comparing to the femoral insertion, it is a very large and shape also varies. That's why I said if already you are having a ACL footprint remaining over there, remnant is there, the things become very easy. You know the width of the insertion as well as shape also. Koff et al., he found that if you are only reconstructing the one bundle, then only 57% of native footprint is restored. So if you are doing a single bundle, then you try to make at least 70% of it. And shape of the ACL footprint is duck foot shape or is the horse hoof shape. There are certain landmarks one has to consider. I'll just use my pointer. Now this is the tibial proximal part of the tibial, and this is the ACL insertion point. Certain important landmarks one has to consider, certain bone mark, that the lateral and tibial spines, ACL ridge, ACL tubercle, medial and tibial articular border, anterolateral fossa, retroeminence ridge over here, and two soft tissue landmark. That is very important, because all the time while doing surgery, you will not keep on taking all the remnant present over there in order to find these bony landmarks. It is not possible. It is also not advisable, because you are distorting the biology. So the soft tissue landmark is very important. That's the anterior horn of the lateral meniscus and anterior. It's not forward. Okay. Here the same thing I was talking. This is the confines of the anterior cruciate ligament. ACL, anteriorly it is anterior tubercle, ACL ridge, and posteriorly is the lateral tibial eminence over here. So the anterior cruciate ligament is 7.5 millimeter medial to the anterior horn of the lateral meniscus. Another ACL ridge and ACL tubercle. This is the landmark for the anteriormost border of the ACL tibial attachment. No ACL is inserted posterior to the lateral tibial eminence, this part. And another landmark you can also use as the PCL, which is 7.7 millimeter anterior to the PCL, is this. So and this is regarding the soft tissue, is as Dr. Rajiv has said, and all of us know that the anteromedial bundle and the posterolateral bundle, basically in the femur, its attachment is proximal and distal, but its name only given after the attachment on the tibial side. So the bundle attached over here is the anteromedial bundle and the posterolateral over here. When we are reconstructing, then the soft tissue landmark are always easy. So this is the lateral meniscus, and we go just posterior to the anterior horn of lateral meniscus. What is my way? My way, commonest, of course, besides this anterior horn of lateral meniscus and the distance from posterior cruciate ligament, my way is I try to find over here. This is the medial tibial spine. So spine has two parts, lateral part and the medial part. So I try to just go at the lateral slanting of the medial tibial spine. That's the place where I want to keep my ACLG. Another method is the fluoroscopy method. That's the intraoperatively you can use the CM. The line described by Amish Jacob, that's the Amish Jacob line. He has drawn this line on the basis of the proximal most part of the tibia as the medial border and the lateral border. And they have just from anterior to posterior, this is from 0 to 100. And what they have found that the ACL insertion of a tibia is around 44% anteriorly. So of course it is more less than 50%. So it is situated more anteriorly, and this is the 44%. There are various studies done on this. Various authors have done. They have used the cadaveric method also, and one study also even in the surgical also. They found this evaluated this Amish-Jacob line, and they found the two important bundle I said, anteromedial and the posterolateral bundle. And in average, they found that anteromedial bundle is around 34.3, and posterolateral bundle is 45.7%, and the average ACL length is 40.2. So sometimes you see if the patient is very tall, but now earlier maybe 5-6 years back also I used to also do a double bundle ACL reconstruction. Now I stopped it because the literature says that not much advantage of doing that. So whenever I was doing this in two bundles technique, then that was again my technique was to keep my both the bundles anterior so that it not incurs over the posterior cruciate ligament. Fluoroscopy guide, personally I don't have any experience of this fluoroscopy guided, that's using the CM during surgery. But if it is simple to use with the CM, is non-invasive, cost effective, because almost all the sports surgeon as first orthopedic surgeon, and when you are orthopedic surgeon, you are having CM inside your OT. So you can just 5 to 10 minutes and use that method, accurate and reproducible. But in the routine cases might not be applicable for all the surgeons, but for the certain cases it is of course useful, because when you are just doing the ACL augmentation technique, when you are preserving the stump, revision ACL surgery where all your bony anatomy is also distorted, there is no remnant available, and chronic ACL avulsion fractures where the fracture has occurred quite old cases where there is all the anatomy distorted, size of the fragment has also become very large. So in those cases, it is still useful, I think, this method as to find the ACL insertion point. Another aiming device is basically the jig. Two important jigs are available. One is the tip aimer, another is the elbow aimer. So usually I prefer to use the elbow hammer, and when there's a remnant is there, then the tip hammer usually I use. And this is the place exact at the, as I said, medial tibial spine where I come, and I keep my this elbow hammer just at the place where I want to come over here, and this I pass my guide wire, and exactly I want this to come out over here. Now again, the complication, whatever the way you have tried to do it, you cannot avoid. If you are not very careful, then this is the problem going to happen. This is the problem. The tunnel is placed anteriorly. Now when the tunnel is placed anteriorly, then the problem is that when you are extending, that your graft is going to impinge over the intercondylar nodes. So there is a loss of extension, and in flexion there is a lacked ACL. So patient keep on walking or doing his activity, all the time in the extension there is encroaching over the intercondylar nodes, and it causes weakening of the ACL and the failure of the graft. Another, if you are again not proper, then your tunnel might be posterior. So you have to be very careful. When it is posterior, now it is impinging on the posterior cruciate ligament. At the same time, your tunnel become more vertical. And when your tunnel is more vertical, then again the antero-posterior stability you can gain, but again rotational stability you have problem. It is very much similar, become like a similar to the transtibial technique. So one has to be very careful while placing it. It should not be too anterior, it should not be too posterior. Similarly, it should not be too medial as well as too lateral also. If you are too medial or too lateral, then you are damaging the condyle, articular surface. Now, first and foremost is the graft harvest and preparation. This is the peroneus longus graft. This is not my routine graft. I used it because the Silence told me last week only. Then in Monday we did. So there is a multi-ligaments injury, ACL, PCL, and MCL. So for ACL, I use this peroneus longus graft. So this is a very thick and robust graft, as we discussed in our previous seminar. This is the outside picture. Whenever you are doing a tibial tunnel, then the position of the knee should be 90 degree, 3 centimeter distal to the medial joint line, usually 1 centimeter proximal to the pes insidious insertion, and 1.5 millimeter medial to the tibial tubercle. Now, the way I have said, first I'll search for my medial tibial spine, keep my elbow remover over there, and I want to exit exactly over the medial tibial spine. Once I found that I have come over there, this is the ideal thing, conforming the position of the K-wire. Exactly I am over the place where if you see from here, posterior horn of the lateral meniscus, here the medial tibial spine, and the 7 millimeter anterior to the posterior cruciate ligament. Exactly it is following all the rules, and this is viewing from the top. The picture I have shown in the beginning is similar to the tibial tunnel. You will find it over here. Once the tibial tunnel being made, that you have to passage of the graft is again very important, because if you not clear the passage, then the soft tissue graft might lacerate. And this is after the final graft placement. Now, after my friend Rajiv has made this femoral tunnel very nicely, and he has kept the suture passer over there. Now my turn is to make a tibial tunnel. First of all, when you have finished your femoral tunnel, that you are very relaxed, because now you are able to extend your knee up to the 90 degree. Because all the time when the knee is full flexed, sometimes your vision is not clear, you are in a panic sort of situation. In that also, if your tunnel is little bit, so you are a little bit stressed. The moment you have finished the femoral tunnel, you are a little bit relaxed, because position is now 90 degree. You have everything under control. So as I said, this is my small video I have. Yeah. So I am just searching from, as I said, my medial tibial spine. I have identified it. I found that this is my medial tibial spine over there. And as I said, the tibial spine has the two part, lateral part and the medial part. So I will just go lateral slanting of the medial tibial spine. I identify over there. And with the use of this elbow reamer, my assistant is passing I am keeping the jig over there so that it should not shift with the movement, and my another assistant is passing the guide wire. Now see, exactly at the elbow part of that hammer it has come, and then once it is being passed, now I have to be very much sure whether it is there or not. So I take out my jig from there and I make a full extension and the flexion, and I have made this video. I'll just mute it. Now, after it has come over there and full extension, I see whether it is impinging on the intercondylar notch or not. Similarly, I will also see whether it is impinging on the posterior cruciate ligament. Once I have very much sure that, okay, now it is not impinging. Now, another step is I use something like a curette over here, because whenever you are drilling, then when directly if you go, then invariantly you will, if you are not very careful, then you might damage the articular surface. That is again worst thing to happen. So you have to protect your guide wire so that whenever from down you are going. Now another thing is, if your my graft is suppose maybe 8 millimeter or then up to that, I'll directly go to that very thing 8 millimeter, I'll directly ream it over there. But my if graft is maybe 9 millimeter or more, then I'll start with the sequential reaming. Another advantage of sequential reaming is, first I go with the 4.5, and if my position is a little bit more, I have to correct it, I correct in that way with the help of focus, and my corrected position I can park even in the condyle over there, and then subsequently I drill with my appropriate size, so that in the first row, if my guide wire is a little bit malpositioned, that can be corrected. After that, here now I am reaming with my reamer, and you can see all the time I am protecting that so that guide wire or maybe reamer. See, if you have not protected it, now this is such a big drill bit, cannulated drill bit would have gone inside and it has just damaged the femoral condyle. Once I have done that, as I said earlier, with the use of saver, I am clearing all my tibial tunnel so that there should not be any bony ridges or the soft tissue passage, because if bony ridges are there, then most of the time all are using a soft tissue graft that might lacerate. And also you have to clear, you want to free passages to be equal. Now with the help of grasper or this suture passer, you take both the ends of the thread that has been kept by my friend Rajiv from there, then I have taken out it from tibial tunnel. So this is the way I make my tibial tunnel. Sometimes what happens, the same, no. Now sometimes if your already your remnant is there, so you want to go to the little bit central and posterior over there, you don't want to damage the remnant already available with you. So when you ream, so it will appear like this. So it mimic like very much similar to the one of the dance described as the samba dance. So it's just movement mimic like that, very that's the name given as a samba technique. So this is especially for when the remnant is already available with you. So this is the way you can drill. So that is how I make my, sorry again, how I make my tibial tunnel. So in order to conclude, one has to stick to the soft tissue and the bony landmark, very, very important. And one should not, because you have been taught for certain landmark, and if there is already remnant is there, you should not keep on taking all the remnant out to go for the bony landmark. So best is rely basically on the soft tissue landmark, especially the anterior horn of lateral meniscus posterior bordal, PCL, and the tibial eminence you can palpate with your probe also. Proper orientation of the tibial guide, very important. You go with the full extension and full flexion. Always check that whether it is impinging. Do gradual reaming if your graft side is very big. And if you are not sure about your placement of the guide wire, you can go with the gradual reaming. And once the first reamer you have used, then you have a room to correct if your position is not at the appropriate place. And judicious use of fluoroscopy especially can be done. With this, I would like to thank everybody again for giving me opportunity. Thank you very much.
Thank you, Dr. Naveen, sir. Congratulations, Naveen, sir. It was really a wonderful presentation, sir. So can you stop sharing now, sir?
From top, no?
हजुर सर माथिबाट
Oh, okay.
त्यो हरियो लेखा छ नि हरियोबाट
Not share.
भएन दाइ
Boy, no, eh?
भएन
Stop
त्यो
share. Stop
Stop
share.
share. Okay.
हजुर
Okay, thank you.
Naveen sir, there is one question from Dr. Jitendra. So
Right.
he have asked about how do we decide at what angle will you fix the tibial tunnel? So tibial tunnel jig. So what will be the angle, sir?
See, basically what happens is also depend on your graft size. So you always try to make a more angle. If my graft is okay, then I will go for the 55 degree, because you see, we want to be more oblique, more horizontal as compared to the vertical. So if you have a good adequate length, then it's better to go for 40, because you want it to be more horizontal. So 55-degree angle is my preferred way to go ahead.
I would like to add here. Yeah, absolutely right, Dr. Navin. The angle of the jig, they say in a standard textbook, is 55 to 65 degree, where we'll get a 3 to 4 centimeter long tunnel in the tibia. And they also, when you make an angle of, use a jig with an angle of 55 to 65 degree, they also give you a specific point, like you said, 2 centimeter medial to the tibial tubercle, 4 centimeter below the joint line. I do agree, but these can be modified a little bit. You can shorten the angle depending upon, as Dr. Navin said, the length of the graft. You can go a little bit medially if you want to shorter. If you have a shorter graft, you can shorter the tunnel. But the standard angle they recommend in the textbook is 55 to 65 degree, so that you have a tunnel, adequate size tunnel of 3 to 4 centimeter of tibial tunnel, and you have an adequate size of graft to put it inside there. These changes in the tunnel direction of the jig has been coming up with nowadays. People do a lot of osteotomies, do a lot of bony procedure along with the ACL reconstruction. In that place, you can modify your angle of the jig so that you can bypass your osteotomies, slope correction, the waist correction, so that the jig can be corrected. Thank you, Dr. Navin. It was an excellent presentation, very practical. I congratulate on you on that. Are there any more questions? I see number one, another question there, Vijendra.
Yes, sir. Dr. Nirav, you were raising hand. So, Dr. Nirav, you can unmute yourself and
Yes,
ask question, Nirav.
thank you, Navin. Very nice presentation. I just wanted to ask you about that type of aimers that you use. Do you have any preference on tip or elbow aimer? And can you please once again clear it for us?
Yeah.
In which situation would you use which type of aimer?
See, the situation can be two. One, there is a no remnant at all, and usually that is the situation. And earlier also used to try when this stump preservation technique was not very popular in the fever of preventing the cyclops lesion and all those stuff. That concept used to be earlier. So in those cases, we want to take out all my this remnant over there, used to take it out, and that so my preferred is a elbow reamer. I always use elbow, so I have a better control on my where I am exiting with the elbow reamer. But when remnant is there, then it's very difficult to keep your elbow reamer there, because when remnant is there, you want to be central or maybe a little bit posterior. You say posterocentral, because you don't want to, while reamer, you don't want your remnants to lacerate or go away from there. So in that cases, with the remnant is there, so I found the tip MR is exactly placed where, because you can go a little bit more posterior and can preserve your remnant. So usually I use elbow reamer, but when the stump is totally preserved there, I want to preserve it, and tip reamer is the choice I go ahead.
What I want
Thank
to
you.
add here is all this, the tip aimer and elbow aimer came with the new companies, the Acufex brought that out. I always wonder, like we usually have to use the bead pin not just once, many times for our patient. We can't change bead pin with each patient. So when you have that elbow aimer, you have that elbow, it doesn't, the pin, is kind of crooked and it comes like that and like that, so it was quite I still don't like this elbow and tip aimers. The ones I started using, in the beginning, the one we had was a Stores aimer. The Stores company had a very nice kind of aimer. They had a hole in the aim so that it would come directly inside. So that was very nice, where you can, there's a hole there, so you put where you want the bit pin to come, and the bit comes into the hole like that. If you have seen that Stores aimer, maybe Dr. Arjun has seen it, Stores aimers, they were different. But the problem with the Stores aimer was the locking mechanism becomes loose, after some years. So we still have that in our cupboard. I still have to fix that locking mechanism, and then you can see the bit pin coming into the hole, and you're confident, whether you have a soft tissue there or not. because even if there is a soft tissue remnant tibial, you can push the soft tissue with that hole, and then you expect the tibial, the bit pin to come into that hole.
One another advantage of that AMR, what Ishwar is talking, that oval has a mark. If you see the two mark, one is transverse mark, another is a longitudinal mark. So that exact transverse mark you can fit over the tibial spine, and the longitudinal mark guides the way how ACL is going. So exactly it comes in the center. It's not tip, not elbow. It's just in the hole. From there it comes. I have seen it, Ishwar, during my fellowship. So this is a nice one.
Nice.
But
Naveen sir,
Amin.
Naveen sir, thank you very much for the wonderful presentation, sir. The jigs are not so accurate, sir. Sometimes what Ishwar says, Ishwar sir just told, sometimes it comes from too medial or too lateral. What is your how do you manage on that situation, sir? Just want to tips and to manage intraoperative, sir.
Yeah, exactly. When I find that my tip is elbow or whatever MR I have used, it is not exactly coming the way I wanted to. The one way is I should redo it so that it came at the place. Or again, it's the same problem is there. I keep it over there. As I said earlier, I go with the sequential reaming. First, I ream with the 4.5, and there I see whether it is coming medial, lateral, anterior, posterior. I correct with that, and we keep my Cocker's forceps over there, and the corrected position I keep my gateway, and then I further ream it. So the tunnel become adequate position.
So I just want to reiterate, what Naveen said. You shouldn't be, if your bit pin doesn't come into the right place, it's better not to remove the pin there, leave it there, or as Naveen said, put another pin is a good idea. But make sure that your pin is straight. You have to see the pin after the bit pin is a one-time use instrument, but we are here using again and again. It definitely becomes crooked, so it does not come to the right place. So you have to make sure that your bit pin is correct. The other nice thing Naveen said was that you ream with an undersized endoscopic reamer. Your graft size is 8, but you feel that there is a misplacement of your guide wire, of your bit pin. You under ream with a 4.5, so that you have a leverage to move the bit pin from inside. As Naveen pointed out very nicely, you put a cocker and pull it towards where you want it to be, and then ream with your exact size endoscopic reamer. Very nicely done.
Dr. Amin, here you better prevent that situation. There are some points you have to follow. The one is you have to lock the jig tightly, and so that it won't oval. So that during reaming, if it ovals, then it is deflected. That the guide wire is deflected to other side, and it doesn't go to the places where you exactly wanted to exit. And another is you better make a shorter, like the bit pin size or the guide wire size should be short, so that it will not be deflected. And another is Dr. Ishwar said, the bit pin is one-time user. We are doing repeatedly. It become blonde, and then it is lifted, deflected with the bending also. And another is that the speed of the reamer also determines whether it is going exactly to the desired exit point or not. The speed of the RPM of the reamer should also be high. That's my opinion.
Thank you. Thank you very much.
Thank you, sir. Dr. Nagamani, you were raising hands, so please unmute and ask a question. Nagamani.
Yes. Good morning, seniors. And Naveen sir, it was an amazing presentation, sir. Sir, 2 points, especially in tibial tunnel, I would want you to clarify for us and our younger colleagues also. One thing is, when you have prepared the tunnel, do you actually rasp the posterior edge or not? Because it said that it acts like a killer bend, just as in PCL. Because it abruptly changes its direction over the inside of the joint. And if you don't rasp it, your chances of tearing your graft can occur. So do you recommend rasping of the posterior part? The second thing is, some people have seen, sir, because they use femoral drill reamers for even tibial reaming, sir. So what is the difference between that, and why would you recommend that a femoral reamer be used for a tibial or not, or it has to be specifically used as in tibial reamer? And if you use femoral reamer, what are the drawbacks for that? Those two things.
Okay, thank you, Nagmani, for a wonderful question. As Nagmani said, using the RASP, because during my presentation, you have noticed that I have said once my tunnel being made, and I use the saver in order to clear the passage. The earlier the concept was, if you people remember when we were doing the fellowship, there's a technique called dilatation or impactor used to be there. So what you used to do earlier, that you under rim the that very canal, and the with the impaction used to dilate it. There was dilator used to be there with the use of hammer and this the further side, so that the with that dilator there is smooth all around, the surface is smooth, so the tunnel become very smooth in order to prevent that. Regarding the RASP, I don't use RASP, but I use my saver system in order to for the same purpose. So I want that area to be smooth. In place of RASP, I am using saver system. Now that dilator or core reaming sort of thing, probably I think 2012 studies have shown about some advantage. After that, I have not seen any literature. If any faculty have idea about that, that dilatation or core reaming is almost gone sort of thing. Regarding the use of RASP you said. So I just use my saver system to clear the passage. Answering your first question. Regarding your second question, the anatomy of the proximal tibia and distal femur is relatively different. So whenever you are using the this femoral tunnel to drill your tunnel on the tibia, what I feel somehow that if your reaming thing is not very controlled, the chances of blowout of the proximal tibia is very high. So I specifically suggest that you should not use femoral reamer in order to ream the tibia. What the opinion of other faculty, let's know. But my view is for the tibia, the tibial reamer is the better, because the quality of bone is different on the proximal tibia.
Yeah, I quite agree. Yeah, I agree with Dr. Naveen that the use of the what do you call that, the roughening you have at the posterior edge of the tibial tunnel. Some people rasp it, some people don't rasp it. I think, I don't actually know what is the scientific basis of rasping there. Probably make it smoother for the tendon to pass. If you have a big size tendon, then if there is too much of a bony roughened edge, it's better if you make it slippery, rasp it and the tendon passes very nicely. I don't think there would be too much of a killer curve like in the PCL, in the posterior tibial in the ACL tunnel, in tibial tunnel for ACL reconstruction. Regarding the second question, I also don't know, probably because like Naveen said that tibial bone and the femoral, femur is more of a cancellous, and if you go too down in the tibia, you have a cortical bone there. So the reamer might, the flower tip and the equal size reamer might make a difference, but definitely, if the company has given you a femoral reamer for the femoral tunnel, you should use that. You shouldn't, use a tibial reamer for the femoral. That you might land up. Maybe Nagmani can put some light on that. Whether we should be doing the opposite way or not. Nagmani, what do you think? Should we use the tibial reamer for the femoral? The only difference I find is femoral tunnel is made in a cancellous bone, so that the reamer is different. And
Well, there
Yeah,
are two points.
in my
Sir,
opinion,
want to say
Nagmani,
something? Yeah. Arjun sir, please.
Nagmani, can I add?
yes.
Okay, regarding the posterior wall of the tibial tunnel rasping, I always use a bar so that it will smoothen the posterior wall, and so that it prevents tethering of the soft tissue graft. This is my opinion, what I do. And regarding the reamer used, that flower head reamer mostly used in the femur, and it is especially useful, in my opinion, in case of if you are doing a transtibial technique. Okay, if you are doing transtibial technique, once you ream the tibial tunnel and going to the femoral side, there might be some variation in millimeter in the site where you are going to stuck in the femoral side, and so that in that situation only that this femoral femoral humor will affect on making the tunnel on the femoral side, I think. But for the tibia, there is some variation in the this characteristic of the bone on the proximal tibia and femur is there. That's why the company has made like that. If you have got only one reamer, in some time you can have only one reamer on the for the both side. I think it doesn't make much harm.
Yeah. Okay, thank you, Dr. Arjun.
Sir, can I make a comment? Sir, we have to move forward now, sir.
Yeah, just last two questions. We have still half an hour. We'll last two questions and then we'll.
Yeah, Biju, I think this point has to be clarified. Vivek wanted to add something.
Let Dr. Arjun
Dr. Nagmani.
and then Nagmani, then we will finish it off.
Okay, my opinion in two different reamers, isn't it? In femur, if you see the femur reamer, it is the head is the standard one, what we want. The shaft is smaller one. So idea is, in my opinion, the idea is when you are drilling to prevent the cartilage, if with the big one like tibia, it will erode friction with the cartilage. So because the shaft is smaller, so head is go through, but the shaft will not touch the cartilage of the condyle. So to prevent that one cartilage damage, so it is made like that. But that can be used in tibia, but tibial reamer to use in femur is dangerous.
Yeah,
that's my opinion.
Sir, can I make a comment, sir?
You are right. Yeah.
Sir, can I make a comment?
Okay, big 1 minute.
The flower-shaped reamer, which is used in femoral side, that must be used in femoral drilling, because if we are going to use tibial reamer into the femoral tunnel, that is the cartilage injury of the medial femoral condyle is bound to happen. So the shaft, it is tapered, and the only flower end is the drilling side, that is bigger. So we can use that femoral reamer in the tibial side. But what happens? It has been shown and it has been published. There is a chance of toggling. If we use the femoral reamer in the tibial side, there is chance of toggling, and because of which the 8 mm tunnel might not be 8 mm. It can be more than 8 mm. So there will be, and in the tibial side, as we know, the bone is softer. We usually go on to have more than 2 mm more screws because it is softer. So because of that, the tunnel becomes wider and there will be a problem with the fixation. I think that is the point why we should use femoral reamer in femoral side and tibial reamer in tibial side.
So the company has given it, use it. So anything to add, Nagmani?
No, sir. Vivek exactly said my mind. Arjun sir added on it, and Naveen sir also.
Okay.
So
Thank you.
concise answer is everything else.
Okay, good. So last presenter, Dr. Arjun, we can give him 15-20 minutes and then we can discuss one another. We have half an hour still. Thank you, Dr. Arjun. Very nice of you to have here. We want you to join us more and present more, and we want to learn from you. So the floor is open. Vijendra, has Dr. Arjun been shared?
No, sir.
Share him and he can open up his presentation.
Okay, thank you, Siswa sir. So Arjun sir, you have already started sharing. So
my screen is visible.
Yeah, it's
Yes,
visible,
yes,
sir.
yes.
Just you can have a full screen, sir.
Yes. Okay, thank you for invitation. Now I am presenting about the graft fixation options in ACL reconstruction. So because time is very limited, so today we are going to learn, share some knowledge about the various graft fixation methods and devices, and concept of ideal graft fixation, its pros and cons. So till now, because there are two methods to fix the graft. One is aperture fixation type, where we use the interferencing screw most commonly, or the other PGA or PK screw to fix the graft in aperture with the graft. The new, or recently, not recently, but in few years, we are now using the suspension type, where the graft will hang inside the tunnel on cortical suspension or the cancellous. For example, the Indo button tightrope on the cortical suspension and the transfix pins in the cancellous suspension. But the transfix pins are becoming more obsolete now. So these are the various methods. Among various methods, the two methods are standard one, where we use to fix the graft. So graft fixation is very important, because without proper fixation of the graft, it is very difficult to get the good result. Because after making the anatomical tunnels in tibia and femur, if the fixation is not good, ultimately it will go into failure. So what is the ideal fixation, and can we achieve it in every case? Because there are some few points, because it should be strong enough. The fixation of a graft, whether it is the patella bone, tendon bone, or the soft tissue graft, just like hamstring or peroneus and anything, but it should be strong enough to avoid the failure against the loads that we do in daily activities or the rehab protocols. So it should be stiff enough. It should not be very thin, so that we can restore the stability of the knee. And we should secure it to avoid the slippage. So after the range of motion exercises, when it slips, it will also go into the failure. So it should be anatomic, because we know that tunnel should be anatomic. So if the tunnel is anatomic, of course, we'll fix it in our position. So it should be reproducible, because if we can do only in few cases and not reproducible, then it is very difficult to use in common cases. And implants should be biocompatible. So it should not interfere with the immunity, or it should not get reaction with the bones or the soft tissue around us. And revision should be possible. Nowadays, there is lots of revision are coming up, because we know that recently we are discussing very much about the transtibial technique. Now it is become obsolete, because it will not, recover the anatomical demand of the ACL. So we are revising some of the cases of the failure of the. So at that time, it should be possible to revision the case. So is it possible? But we have to try to achieve all these demands of the graft fixation. So because we know that, and the friends have already, other senior faculties already discussed about previously about the types of graft. Whether we generally use the graft, for example, few years back, we are using bone patatendon bone that has the two bone ends on the two sides. So generally we use interference screw with the aperture fixation method. Nowadays, quadriceps graft, with or without bone plug, we can also use that one. And now the soft tissue grafts are coming up. For example, the hamstring, the most commonly with semitendous and this gracilis. Now the peroneus and ectendoachilles is also coming up. So this graft doesn't have the bony ends. It has only soft tissue. The other type, because when we fix it in the femur or tibia, because we know that we have already discussed, because the bone density inside this femur and tibia are different, because the bone density tibia is a very much cancellous, just below the articular surface. And the angle of line of force with the graft is very straight in tibia, because the in femur, the tunnel is slightly angled. So the pulling of the graft is somehow restricted. But when in the angle of line of force is in the line of the fixation, then a slippage, the fear of slippage is very much there. And we know that when you are using the bone, patatendon bone, there is a bony inside there. So the healing will occur in the bone or the condyles. It will take around 6 weeks. But when the soft tissues graft, when we are, for example, in hamstring, it will take longer time, maybe 12 weeks or more than that one. And now in some countries, they are using allograft, it will take much more longer time. So we need to see the nature of the graft and fixation devices so to achieve the better fixation. Now we need to know some of the biomechanics of the graft, because the graft, when we fix it with either with aperture fixation or the suspension type of them, there's some motion occurring inside the graft during the daily activities. There are said that it has a three kind of motion. One is longitudinal, the other is horizontal, and other is a creeping of the graft surface. Because when we extend or flex the knee, there's a longitudinal motion occurring between the graft. So if the fixation is not good enough, at the time it may become loosened gradually. So that if the graft motion is more than 3 mm, the incorporation of the graft will be disturbed. And the other is the wind wiper effect. There is a horizontal motion, because during the movement, especially in this suspension type of fixation, the tibia in respect to the femur may move anterior and posterior. So it is the horizontal motion. So this can cause the tunnel widening. So tunnel widening, of course, gradually the implant will become loosened with the intersurface of the condyle and may become loosened. The other is the creeping effect. Because during the fixation of the graft, we use this range of motion to strengthen, to lengthen the graft, to give some stress to the graft. Maybe we are generally using the 20 times we use the forceful extension and flexion, so that the graft will become taut. But during the activities, it will again become some creeping and elongation occurs to some extent. It is said that maybe 2-3 mm whether in the FRC fixation or in the suspension type, some kind of elongation is occurring to some extent. So we should know that how much force is needed for the graft or the for fixation to it can bear that load or to become failure. So it is shown by data that the BTP graft, it can bear up to 3,000 Newton of the force during the activities. It may be the cadaveric kind of experiment. The 4-strand hamstring, it can bear much more larger force. It's a 4,000 Newton. So it is said that the hamstring, 4-strand hamstring, is much more stronger than the BTP graft. It is said by the data. And in the fixation interface, it needs only the 500 Newton to become to load for the failure of the fixation. So much more smaller force can give the failure of the fixation. So during the ACL reconstruction, during daily activities and the rehabilitation programs, maybe it is 150 to 500 Newton forces applied. So you can see that the failure fixation of the device is 500 up to the 500 Newton, and during the daily activities, it may reach up to the 500 Newtons during the strenuous activities. So there is a very limited difference between these two activities and the load bearing area, load bearing capacity of the fixation. So we should be very careful about the early rehabilitation program, the activities, especially when the fixation is, you are not very satisfied with the fixation or the patient is osteoporotic, then we have to be very, very careful. So during the first 6 weeks, the graft subject to the 220,000 such cycles. So the repeated force can cause the graft failure. So there are many hardwares for the graft fixation. Now it is coming gradually. Maybe decades back, we are using only the stainless steel interference screw or the titanium screw. Nowadays, it has come with several new hardwares to fix. Because the interference screw, there is still, but that has become already obsolete. Now we are using the titanium in some cases, and the other is the poly screws, for example, PK screw or PGA. And the loop with buttons, there are also for the suspension type of fixation, it is available. The first generation is the fixed loop type of Indo button. The now second generation adjustable loop fixation is available, which is much more, some of the cases, it is much more comfortable to use. And except that one, in some of the cases, we can use the staples, screws with spiked buttons, washers, etc. So after using this one, we can use in multiple the fixation devices at the same time. When you use a single fixation is tunnel, at the time it is called simple one. But in hybrid fixation, we can, in addition to the simple fixation, we use this post staples buttons can be used when you are not satisfied with the simple kind of fixation. So what is the advantage of the FRC fixation? Because FRC fixation, when we used to do it in most of this patella bone, tendon bone graft, and nowadays in some of the cases of the soft tissue graft also, because it has a minimal tunnel motion, so it will prevent the tunnel widening. It will of course tunnel widening and the failure, and the creeping also less. But sometimes with the soft tissue graft, it has to some extent can cause the laceration of the graft, because the thread of the interference screw is very smooth one. But sometimes the tunnel is very tight. Sometimes it can cause the multiple bundles, maybe 1 or 2 bundles may become lacerated during the standing or during the giving some tension up to that one. So the interference screw, the screw fixation is affected by some of the fewer factors. For example, length of the screw, it should be appropriate. The size of the screw. For example, when you use a femoral condyle or the tibial condyle, maybe in the graft fixation, we use the same size or the one side larger in the soft tissue fixation. But in the bone pattern tendon bone, we use the one side lower one, the size of the interference screw in the femur. But in tibia, because it's much more cancellous, generally we use the 1 or 2 size larger interference screw. And the third point is the geometry. Of course, the geometry is made by the hardware. These companies are is a good one. But sometimes the threaded, the size of the thread, if it is not proper one, it might cause the failure graft. The other thing is the most commonly we encounter is a divergence of the screw, because we have that tunnel and you have put the nitinol wire for the guiding the way of the this implant. But sometimes when you are not very careful during the, because Newton wire is very weak one, it may become a little bit flexible and the lots will be there. So the screw may go in the some other direction because the bone is cancellous. So if you use some of the forces during the struggling of the insertion of the screw, it may go in the other direction. So if it is more than 20 degree of the divergence, sometimes that the fixation will be loosened and may cause the failure of the graft. The other point is the screw material, the bio or the metal, because titanium is, we know that the stainless steel, this screw is not good enough, because stainless steel interference screw, generally the soft tissue will cover that one. But nowadays there is a titanium screw, so the lots of bone growth can happen in the titanium screw. It is better. Nowadays bio screw also available because the patient are not a bit reluctant to use the metallic screw because they are going outside and they don't want the siren buzz in the airport or such demands are also there. So because it can degrade biologically and replaced by the biological tissue, maybe the bones. And the BMD, the bone mineral density, also very important in the to securing the graft, fixation of graft. Because of course, if the bone is very osteoporotic one, the fixation will be loosened gradually. So at that time, you may need the hybrid type of fixation. And the other is the insertion torque. Of course, if the bone BMD is good, the insertion torque is better, and you can satisfy with the fixation. But if it is not very good, the porotic bone, at the time you need to tackle with some other fixation methods. The advantage of bioscrew, as we have already said, that it is because replaced by the host tissue and no need to remove later on, not visible in the X-ray. It will not give the metallic detection during it. It can spare that one. It's a non-toxic, and it has no interference with the MRI. And it has also better, it is said that it has better pull-out strength. So bioscrew is becoming much more popular for the screw, this aperture fixation type of fixation. But there are some disadvantages of the bioscrew also, because the screw breakage, because the company will say that it will not do that one, it will be strong enough, but sometimes the screw breakage may occur during the inadvertently during the fixation or later during the rehab protocols. So it will loosen the fixation. And some of the bony ingrowth may be incomplete in some of the cases. And some allergic kind of reaction may occur to some patient that may cause the osteolysis, effusion, and sometimes the infection. So in such a cases, we have to prevent the patient, after knowing the history of such a infection or those things, then we have to prevent from the this bioscrew. And the other fixation device is the fixed loop or the ancestral loop. For several years, we have used the Indo button. That's the fixed loop type of first generation, the suspension, the fixation. So we have used that one for a longer time, but it is a strong one, except that because it may cause the tunnel widening after this widening, this wiper effect. But the problem is this Indo button is because we have to drill some additional tunnel, because in a Nepalese patient, because we have already said that some of the patient is only the tunnel length is only 28. So if you want the graft to put the 25 mm, then you have only 3 mm of those cortexes remain. So at the time, if you want to over drill that one, it will perforate the cortex, and maybe the graft the Indo button will also submerge in the bone. So at that time, it is very difficult to adjust the graft, because due to Indo button flipping mechanism, we have to drill 8 to 10 mm extra. So at that time, for such a small patient, especially in the female patient, so there's this irreversible loop kind of, it is a brand name, maybe the tightrope. So it is very useful, because you need to drill only that portion of the graft. If you want the 20 mm or 25 mm, you drill only that portion. So automatically the pulling effect, the shortening effect of the pulling the threads will get the graft inside. No need to drill extra tunnel inside the condyles. But you have to ensure the button whether fully seated on the cortex or not. After flipping, maybe it is in the soft tissue sometimes. So if you're not aware of that one, after the fixation and the patient goes to post-op or in the ward and you get the X-ray, at times sometimes the Indo button is not sitting on the cortex of the condyle, but it is in the soft tissue. So to prevent that one, you have to be very careful. You have to make an extra little bit incision and feel it by the finger, whether it is sitting on the cortex or not, or you have to use C-arm once for a few seconds to see whether this button is on the cortex or not. And the other advantage, the good advantage of this tightrope is that you can do the final tensioning. So even after fixing all these things, because Indo button cannot do that one. This fixed loop cannot do that. Adjustable loops and suspension device can, after fixing all those things, you can pull again the shortening thread and make sure that the graft is tight inside the tunnel. So in conclusions, there are two methods of the fixation, and the many graft options are there. Categorically, it is a bone with bone plug or without bone plug, and the devices are many of kinds. So you have to judiciously use whether you are using the bony plug or the soft tissue, or the bone is osteoporotic or not, the demand of the patient, the type of the graft. You can use the judiciously those implants. But it is said that the clinical results of various methods are comparable. There's not big difference in the large population. It is said that apparatus fixation theoretically better. The interference is the gold standard till now. But nowadays suspension device is using much more because it is relatively comfortable for the surgeon to use the graft, harvesting hamstring, than the patellar tendon, because we know that the some complication of the bone patellar tendon is there. So tibial fixation due to the soft bone, it is a greater risk, and tunnel widening is much more common in tibia. And we know that during rehab, fixation is the weakest link in the early postoperative period. So we have to be very careful during the rehab and early recovery stage of the ACL reconstruction period. And the hybrid fixation is becoming popular because there are now, because you are not satisfied with the fixation, you want to use the patient porotic, and the graft length is not good enough. So at the time, it is wise to use some other fixation, because staples or the washers or the post for the assure your fixation, so that it will not go into failure during rehabilitation till the graft incorporates into the tunnel. So thank you very much.
Thank you, Arjun sir. Congratulations for your wonderful presentation, sir. Arjun sir, can you stop sharing, sir?
Yes, I'll try to. Oh, sorry. It is not okay.
Okay, Mati, stop sharing one. It's only, sir.
Stop sharing. Yes. Okay.
Thank you, sir. Sir, there is one question from Dr. Devendra Acharya. So he has said that very informative presentation. Thank you, sir. So what is your experience on using biodegradable screws? Have you come up with any complications, and how do you address the problem?
Generally nowadays, because decades back, I have also used the transtibial method and in all the patient, the bone patellar tendon graft. But nowadays, gradually shifting towards this hamstring soft tissue graft and the suspension type of fixation in the femur, and in the tibia. Till now, we are still using the aperture fixation. So in tibia, most of the time, I'm using according to the patient demands, I'm using this biodegradable screws. And till now, I have not encountered any problem with the biodegradable screws.
Okay. Are there any more questions?
So chat box ma to chaina. So if anyone want to ask, they can unmute themselves and ask.
Yeah, I just want to follow up with Dr. Arjun. Thank you, Dr. Arjun. It was an excellent presentation.
Thank you.
I just wanted to ask, yeah, you are one of the senior person, but since you trained in Japan long time back, isn't it? When was it, Dr. Arjun? You came back in?
Really, it was in 1999 to 2000.
So you see, I've always been fascinated, like this metallic interference screw, which was started by Professor Kurosaka. Probably you met him. You must have used that interference metallic screw quite a lot, when you were training, or must have seen that, or were they already starting using biocompatible, bioabsorbable screw?
No. At the time, only the Kurosaka screw. Only that option is.
The metallic screw were being used. Isn't it?
And before that one, before using BTB, my teacher was using, before I was there, he was using the synthetic ligament. That's the lead skew, this ligament, synthetic ligament with the ITB, wrapping with ITB. And he's using screw in the femur and the staples in the tibia. He was also using. So he was revising lots of the cases with the BTB later on.
So what I wanted to ask was like, this Kurosaka screws, which were started from Japan, by Professor Kurosaka, must have I mean, he presented a lot of mechanical scientific basis on that, and these are usually the implants, the Indian implants that are produced here, which we are using. I probably think we never use a Japanese made interference screw. So what difference was it like where we find now with the metallic screw, cutting off, laceration of the screw? Was there a difference between the Kurosaka screw that was original and the Indian ones? Do you have any experience on that? What was the difference you found with the Indian made interference screw?
Yes, now I remember that it is the color is a black one. It is tapering. It is tapering. Head is a little bit larger and slightly tapering, and it has those threads are a little bit deeper, and it's also smooth but deeper threads than what we are using now in the titanium screw. So that's the difference. But after coming to Nepal, I have never seen that one.
So you see, that was what I was. You must have had a lot of experience, So you rightly pointed out, in any kind of ACL reconstruction, the weakest point is the fixation, the tendon being fixed to the bone, and all this improvision in this fixation implant has, improved our success rate of the surgery. The problem we are facing quite now with the use of bioabsorbable screw, and that is coming up, is the pretibial cyst that seems to be forming, and now people are going into biopeak and biocompatible things, So let's see how it goes with those things. To tell you frankly, my preference is, like you said, the hybrid fixation we do for the femoral tunnel adjustable, suspensory fixation, and then a interference or aperture fixation for the tibia. And we also started with the interference fixation both in the femur and the tibia, and we changed to the suspensory fixation. But it's because of the ease of doing that flipping, you feel satisfied when you put an interference screw, you are squeezing the tendon to a side, and you don't feel comfortable that the aperture you make is not completely filled by the graft. And I think that is the golden standard, as you said, hybrid fixation. And when you feel that the tibia fixation is not good enough, that is from experience, you don't feel that torque, you should go on with a supplementary fixation. And of course, in our context in Nepal, that means that it will increase the cost. So biocompatible screw itself are very expensive, but I hope the Indian companies are now coming up. They can at least reduce the size reduce the cost, half the cost, so that it can be available to all our people, when we use the bioabsorbable Indian biotech screws, that would reduce the cost. The cost is a main factor for us for any kind of surgery here. Are there any? Yeah, Bijendra, you can
Yes,
go.
sir. Yes, sir. There was one answer which was already answered by Arjun sir. So question was asked by the Dr. Jyoti, and he said that when the bioscrew at the femoral side was broken, what is the effect of bioscrew in the joint? It could not be removed as it is a radiolucent. So Arjun sir has answered like that. It may have effect of foreign body reaction sometime. Loose body effect may be there, and the locking and the synovitis or the cartilage injury can occur due to that broken bioscrew.
Yes,
So
thank
any
you.
more faculty want to add something, or
If it is inside the joint,
Arjun sir?
It must be removed inside joint using the arthroscope, because it's the radiologically it's not opaque. That's why using I have not encountered such complication, but one should remove completely those fragments.
Dr. Nagamani, you are raising hand.
So the famous question, Iswar sir and all, we're talking about fixation. What about press fit techniques, sir? We decrease the cost, we decrease the implant related complications and other stuffs. And it's been well proven in literature. So two things, sir. We are talking about bioscrews when the metal literature has proven time and again that interference screws metallic are better. And we have availability of Smith and Nephew as well, sir. And I have an experience of seeing so many cases where there was no cutout, and it was in hundreds, sir. So basically, a relatively high volume center, I've seen metallic interference screw on the femoral side. But yet we always talk about graft being cut by metallic interference screw when the literature doesn't support it, and I haven't seen it, sir. And the second thing is press fit has been an acceptable method, and the biggest advantage what they say is the revision is easier. The second thing is when biomechanical testing was done, as sir said, it is able to tolerate equivalent to your fixations, 500 Newton per day. So it doesn't fail that easily if it is done. The third point is if you have you don't achieve a press fit fixation, you can always use a interference screw to fix it, Kurosaka, which you were talking about. So one screw only needed, sir. So you save implant related cost, you prevent implant related complication, and then we are favoring for all those bioabsorbable, whether it's peak or anything else, rather than focusing or trying to shift whether our technique is wrong and we should move towards the metallic interference screw. Is that company driven, or is it just that we all are looking for it that way, or we are not trying to look at some other point of view, sir? Comments from the seniors, sir.
I didn't get your question, you know, you put it so gumauro tarika le. Can you just straight ask, you know?
Why not implantless? Why not metallic screw? Simple as that, sir. Are we overwhelmed by companies or distributors promotion, because they'll definitely want to make an immense amount of money is used in that, sir. Because your last point was cost has to be decreased. Yes. And that comes to Nepali context, and I've given you two examples how we can decrease the cost, and why aren't we shifting towards that? That's my question to all the seniors, sir, including.
My simple answer is, why not metallic screw? One is that if you have to revise, it's better if you don't have any metals inside. It may be hard to remove. Of course, I agree. It's very cheap, you know. And
then why not press fit, sir?
The other thing I want to add, you know, the other thing is like the metallic implant we have in India is not the same metallic implant that Kurosaka devised, you know. There is a difference, you know. That is why I'm always asking, you know, this Kurosaka. Of course, I attended his lecture, I think in Hong Kong or in Australia. He gave a very scientific mechanical background, which some I understood, some I did not understood, you know. The other thing is press fit. I don't have any experience, to tell you frankly, you know. And another last thing to add on that is we are all driven by company, you know. It's not just you or me or, you know, the whole orthopedic fraternity has been driven by companies, you know. And even, you know, you can say, of course, we should not depend on that, but even the patient becomes a factor of that, you know. The patient would want to come and say, you know, like, sir, is this implant going to remain in my body? Do I have to remove it? You know, then you are left with a metallic that can be seen in X-ray. And then at least even if the bioabsorbable doesn't get absorbed, we know that, you know, it doesn't get absorbed, but we say that there is nothing there, you know. You don't want to do two operations, you know, in a patient, in a ACL reconstruction. That is my view, you know. For a press fit mechanism, you know, you should popularize it, you know, make not only a retiring surgeon like me aware, you know, everybody, and then you can hope that it
You're not a retiring surgeon, sir. You still have 10 years to go.
It becomes a routine procedure in your time. Yeah. I hope you will.
Okay, Nagmadi.
Yeah, I surely will, sir.
I hope you
Nagmadi. Yeah, Dr. Nagmadi, I agree with your
surgeon,
cost making the less is possible. Regarding the press fit technique, I think it is typically more demand got to be used to with that technique.
Sir, every learning curve in arthroscopy takes some time, sir. Once you do 20 cases, you will be well equipped to just add 10 minutes of the time and finish it, sir. But the problem is we are not yet looking at it in an open way, sir. That's the problem, because we're sticking all the same technique. Maybe we should broaden our horizon. That's my point, sir. Because in our context, in Nepalese context, adding 15 or 20 minutes of your time to an implant less when the outcomes will be just the same. Why it? Because most of our debate about is about cost at the end.
Let Dr. Arjun also speak, Nagmani.
Yes, press fit technique, because the professor from Philippines represented this one. And one fellow, I met one fellow who got some.
Okay.
He said press fit method is equally good without implant. It is very good, but I have not seen that one, so I am not able to try that one. I want to try that one, but I have not training with that one. So till now, I don't have any experience with that one. But the metallic screw, it can be used, but we generally tell the patient that you want this one or that one, because this one metal is visible and sometimes you may need to remove. But later on, it's expensive, bioscrew is expensive, and it may not be visible. At the time, there's choice of selection for the patient, as we should give to the patient.
So Dr. Arjun Lamisane wanted to comment. Yes, Dr. Arjun Lamisane.
Yeah, regarding the cost, I think the Dr. Nagmani point is valid, because even with a metal screw also, you can have a soft tissue thread and this bony thread also. This company, different company made in that way. And another way to decrease the cost is like we have many times heard the lecture of B.V. Vasan from India, Gangaram also. He is using a simple washer for the fixation. So this is very cheaper also. There are various options. I agree with Nagmani. We are partly driven by the company also, and with the patient also. As Dr. Arjun said, the patient also wants any implants that is not visible in X-ray, that doesn't need to be removed, and that also guides the technique of fixation to some extent.
So, sir, can I make a comment, sir?
Please.
Sir, during this type of discussion, during this type of scientific gathering, what we always, when we talk about the femoral tunnel and tibial tunnel making, we show the X-ray example of X-rays when there is the wrong tunnel placement X-rays with the metal screw inside, right, sir? So we are doing so many of our cases with bio screw which are not visible in X-rays. My question is, are we making wrong tunnels, but making ourselves overconfident that we are making good tunnel, because these are not visible on X-rays? Because whenever wrong tunnel placements are shown as an example, only the metal screws are the X-rays with metal screws are shown.
No, Vivek, I disagree a little bit. You know, even with the bio screws used, the tunnels can be seen in the X-ray. You know, the Amis and Jacob evaluation is an X-ray evaluation. You can see the tunnel. As far as I know, you know, it doesn't need to be metallic implant to see whether you have the proper tunnels. You can do an X-ray with a bioabsorbable screw and then the endo button at the cortex, but you can still trace the tunnel and see whether you have made the tunnel properly with an X-ray. As far as I remember, you know.
That's right. That's right.
I think. Yeah.
What I want to add, Vivek, see, X-ray is you are seeing and you are satisfying yourself, but the problem occurs when patient come to with the problem. Patient is having a problem like extensor lag or any other problem, then you are more conscious. Okay, with metallic screw is there in X-ray, you can go ahead. But even if you are using a bio screw, MRI is always there to check. So if you are to be 100% sure, do the MRI and see where is your tunnel.
Yes, Dr. Arjun.
Yes, I'm also saying that you can see the tunnel tract in X-ray. That can also show us whether the tunnel is proper or not.
Yes, agreed, sir. But problem is tibial tunnel is usually visible, and if after about 2 to 3 weeks, we cannot get the good lateral view or good absolute lateral and true AP and true lateral view. So the typical tunnel, the shadow of tunnel in bio screws are not well visualized as in metallic screws. So the femoral tunnel, that same holds true for the femoral tunnel. So what I mean to say is I'm not in favor of any metallic screw or the bio screw. Both had advantages and disadvantages, as we have already discussed. My point is, are we undermining our wrong tunnels because we are not seeing those routinely in our X-rays, like the metallic screws? That is my point. I want to raise a discussion only, sir.
Well,
Okay. Can I say something? Should I?
Rajiv, you want to say something?
So this is quite a long rebuttal, okay, mostly to Nagmani, then I'll come to Vivek also. I've just been listening to everybody. So to respond to Dr. Nagmani's first question, why don't we use the interference metallic screws? Because at the time when I saw the interference metallic screw, definitely they were quite barbaric. Okay, those screws used to cut the graft. That's why I stopped using them. And after that, I've been very comfortable with the other technique that I'm using. I am not really driven by the companies, maybe partly driven, but I am driven by the good results that I've achieved in my patients. Okay, so I am sticking to what I use today. Okay, now definitely the new generation has to come, and this press fit is definitely good. As you say, you've seen hundreds of cases. I don't have experience with press fit. Why don't you do some cases? And I think I will definitely follow a press fit from today also, and we'll see. Okay, and I've definitely seen that improvement from the bookshelf to Mount Kailash in the background. Dr. Nagmani, very good background with Mount Kailash. And that probably led you to ask that question regarding why don't you use the femoral flower tip jig in the tibia? Okay. So, I mean, Vivek gave a very, very nice explanation, very, very logical question, Dr. Nagmani. So I think probably, my explanation would be, with all that Vivek said, agreed. I think, when we make that tunnel into the tibia, the space is very compromised. Okay, the space is very compromised. Yeah. Now, if you put a tibial the tibial drill bit into that compromised space, it's going to hit on your medial femoral condyle, because see, it's a very broad drill bit. Okay, but if you have a flower tip where the tip is very broad, okay, and the rest of the drill bit is slim, then there are less chances that the medial femoral condyle will be injured. Because see, when you're taking the knee up to 120, it is very, very compromised, the space. So I think that's my explanation for that. Now the next one is, you used wonderful questions. Now to respond to Vivek, yeah, what was the Vivek? What was the last question Vivek asked right now?
So my question was, are we undermining the wrong tibial tunnel or wrong femoral tunnel, because we are not seeing those routinely?
Yeah, exactly. So Vivek, to respond to that, I mean, last time I said, right, I mean, I'm sure many of you all don't do it. I do a post-op X-ray. I do a post-op X-ray, and I try and get a good lateral and an AP view. And that helps me to make an assessment. Okay. So if you look at the lateral view, it's about 43, 44 degrees from the front. Okay. I mean, sorry, the length of the tibia from anterior posterior. So I calculate about 43, 44% from the front. So that's where my tunnel should be. If you look at the AP view, then I calculate about 83% from the medial side of the tibia. Something like that. There's a calculation like that. So that will help you assess whether your tunnels are in the correct place. I think that's what I have to say.
Okay. I think, are there any comments, any questions? Yes, Dr. Raj.
I want to say, for the beginners or the who are doing the daily those arthroscopy in the initial stage, my suggestion is just advise is that take a glance of C-arm during the tunnel guiding. When we put the guide wire for the first few cases, maybe the 10, 20 cases, then we will get the experience, then we can avoid that one. But that is the best way to learn, I think. Take some pain.
Okay, thank you. I think we are quite up to limit in our time, but not that far overdriven. So I'll just give a 5-minute, summary, so then we can close down and spend our Saturday morning, even the COVID is out there. So we had a very nice talk from Rajiv, then from Dr. Naveen and Dr. Arjun. Thank you very much for actively participating. It is our society, we have to be active, and then we will be here for our younger guys, to give them some little guidance, how to do things. Rajiv talked very nicely about the femoral tunnel. The concept is anatomical femoral tunnel transportal, and there are many techniques of doing that. The usual easiest one, what Rajiv is doing, was shown very nicely. You always attach with a senior guy and you learn from him. Everybody does like that, and then you become an expert yourself. You make some mistakes, but later on you can, you have to reflect on what you have done, and then you learn from that. very nice presentation from Dr. Naveen also, tibial tunnel. The 3 points I very still remember is that 7 millimeters in front of the PCL, just behind the anterior root of the lateral meniscus, and stay lateral to the medial tibial spine. That's the standard. That is the point where you should come out, and it rightly said that your graft does not fit the whole of the tibial footprint. Freddy Fu, cuts his foot tibial attachment, shows 16-18 millimeter, and the largest diameter of the graft we get is 8 millimeter. Thank you for that. And lastly, Dr. Arjun talked about the fixation, and this point I want to stress here is that the weakest point in our ACL reconstruction is the fixation. Of course, the graft we have harvested, hamstring, the BTB is, I don't exactly remember, is very strong, has a high, the high, the strongest, even from the native ACL that is there, the graft we harvest, the BTB and the hamstring is quite strong, but the problem is the fixation. Wherever it fails, the fixation has to be improved, and science will evolve, regarding whether using a absorbable or metallic implant. You have to stay with the time. The profession drives with the company, in a way, I would say. And for the Nagmani's point of, implantless, I want you guys to start that, and tell us, after we are, in our old ages, that I've done this, sir, this has cost the price, and our people, our poor people in every, aspect. I have been fortunate enough to have younger surgeons like you who do not use implant, and cuts the cost by more than, a lakh. That is, it's there, 60-70,000 for the implants also. I always think about that, but what can I do? I don't have that implantless technique. You guys should do it. So with that, thank you all of you who have been participating in this webinar series. I wish Sailaj was here to say hello, but he's not here. He must be shivering in London's cold, winter. All the best for him also. Thank you, all of you. Thank you for, joining in. We will see you again in the next one. I mean, now Dasai is already here, it's knocking in the door. So happy Dasai to all of you also. Let's see whether we can meet again before Dasai or after Dasai. But thank you. Bye for now. Okay.
Thank you. Bye.
Thank you, sir. Bye-bye, sir.
Thank you. Bye.
Thank you, sir. Bye, sir.
Happy
Have a
birthday,
great
Ishwarai, again.
Okay.
Thank you.
Thank you, sir.
You guys are making me feel old,
Okay.
You don't look like that, sir.
Didn't get birthday.
Finally, we can see Arjun Dai. Nagmani ran away. Where's Nagmani?